Well, welcome everyone so much to our very first formal seminar in our PhD seminar course. So before we get started, I'd like to offer a land acknowledgement. And as this is a hybrid event and some participants are on different territories, please take the time and space to give thanks to the land that you're currently living and working on today. So we're here at the York University campus in Toronto that is situated on a traditional territorial area known as Toronto, and we acknowledge its current treaty holders, the Mississaugas of the Credit First Nation. We also acknowledge this as the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is subject to the Dish with One Spoon Walton Belt Covenant, an agreement to peaceably share and care in the Great Lakes region. And we realize that this acknowledgement is really just the first step in building closer relationships with our Indigenous communities, and we look forward to opportunities to do that. So we're very fortunate today to have Professor Benjamin Ewert join us from Germany, actually. He's a political scientist with a specialization in health and social policy, and professor of politics for health professions at the Department of Health Sciences, Fulda University of Applied Science. He holds a Venia Legendi in political science from Heidelberg University and a doctorate that he earned summa cum laude in social sciences from the Justus Liebig University Giessen. Professor Ewert he's held teaching and research positions at several institutions, including University of Sagan, Venia Universitat in Hagen, and Heidelberg University. He's been involved in numerous EU-funded research proposals, such as the welfare innovations at the local level and integrated palliative care projects, contributing both as principal investigator and collaborative researcher. He's also conducted international research studies in Manchester, Venia, further enriching his global perspective on health governance. As a committed educator, he's taught at a wide range of seminars in health policy on social innovation and behavioral governance. He's organized academic conferences and workshops and presents his research at international conferences. His scholarly contributions have been recognized with the Ken Young Best Paper Prize in 2022. He's an active reviewer for numerous journals and funding bodies, and he's currently involved in institution building and governance roles at Fulda University and maintains a strong engagement in the academic community through his editorial and peer review work. And so I would like to pass it over to you, Professor Ewert, to begin your talk.
Good afternoon, everyone. Thank you very much, Mary, for the nice introduction. I'm very pleased to present today at the Dadalé Institute for Global Health Research. And my talk is titled, as you already know, Rethinking Health System Resilience, Concepts and Controversies, particular in the German context. In the next 20 minutes, I will highlight why the political dimension of health system resilience is often neglected, what we know from a systematic review of the multidisciplinary literature dealing with health system resilience, and how these insights play out in the German health system context. So I will switch to my second slide. Let me start with the guiding interest of this presentation. I formulated two hypotheses that will frame my work. First hypothesis, in current health system resilience research, political determinants remain underexplored or even obscured. And second, in the German case, resilience policies tend to reinforce existing governance structures, which mean the status quo of the health system, rather than transforming the status quo of the health system to something new, something unknown. So for me, the interesting question is, how political is the concept of health system resilience, or how political can it be, both in theory and in practice? As global health scholars or global health PhD students, you probably have read articles on health system resilience. You are aware of at least the term, and already noticed that resilience has become a buzzword in recent times with multiple meanings. So on that particular slide, I offer you different attempts by scientists, social scientists, to define the term. A rather far-reaching definition says health system resilience is the ability to prepare, absorb, adapt, and transform. It's far-reaching or comprehensive because here it's also about transformation, not only about adapting to a new status quo, or to a new situation, or to a situation of crisis. But other definitions term the concept by emphasizing that it's all about bouncing back to or continue to function and return to a rather stable equilibrium, which means to a rather static status quo of the health system. And then we also have the notion of everyday resilience, which means that health system needs to respond to day-to-day to several challenges, shortcomings, and crises on a day-to-day basis, beyond of the situation where we face pandemics, wars, or other major crises. The core ambiguity, however, remains. It's not exactly clear resilience against what exactly, and this is not clarified by these definitions. Therefore, it's a multifaceted framework. I would like to distinguish particularly two frames: a global health frame that emphasizes solidarity, global security, and multilateral responsibility, and on the other hand, a health system frame that looks inward, focusing on national institutions and domestic reforms when confronted with crisis. Of course, both frames are relevant, but they highlight very different political logics. I would like to introduce briefly the concept of political determinants of health. Here, my argument is that resilience is not just technical or organizational. It is deeply political, and therefore it's useful to draw on the concept of the political determinants of health, because this framework includes structural conditions and power constellations within health systems, the role of institutions, veto players, and path dependency, and the way policy negotiations shape reform outcomes. And here the argument is that if we ignore these political dimensions, within health systems or at a global health stage, we risk misunderstanding why resilience strategies succeed in a particular context or fail. To explore the nexus of health system resilience and the political determinants of health more systematically, I conducted a scoping review of the multidisciplinary literature from the start of the Ebola crisis in 2014 to 2025. I searched 3 databases, PubMed, Web of Science, and Scopus, by using the combined search terms health system resilience with politics and governance. This led to more than 1,500 initial hits, which I reduced by applying the following screening strategy. It's first, I asked, does the specific article introduce at least a minimal health system resilience concept, provide a theoretical framework, or engage in a detailed discussion of this concept? And then in a second step, I asked whether the source examine policies related to health system resilience, analyze political decision-making processes, or explore governance dimensions relevant to resilience. This allowed me to include 51 studies in my final sample. I studied these 51 sources in depth. And here are my examples. Of course, the findings reveal several trends, but, and I think this is no surprise, there was a surge in publications after COVID-19 with a peak in the year 2023. We see a dominance of health and social scientists who are interested in the concept of health system resilience in combination with political determinants of health. Key journals are the BMJ Global Health, BMC Health Service Research, and the International Journal of Health Policy and Management. However, a key takeaway is that even in the studies which combine health system resilience with political determinants, these political determinants are treated superficially and do not play, or are underrepresented, represented, sorry. And a good example is this Nature Medicine article from 2021 by Victoria Haldane et al., Health System Resilience in Managing the COVID-19 Pandemic, Lessons from 28 Countries. Scholars state that health system resilience policy require governance expertise across levels, sectors, and domains, and depend on a system's ability to reach vulnerable populations. However, they do not go into further detail. Yeah, they just notice that, of course, governance expertise across levels is important, but are not go into the politics which are necessary to make governance work. Other findings are, or some other findings, most studies highlight adaptive leadership, accountability, or multi-sectoral collaborations as facilitators of health system resilience, but only a minority critically engage with power relations, institutional constraints, or political struggles within health system or at a global health stage. Very few studies point to civil society and community participations as leverages to make health system resilience work, but also not in a systematic manner. Again, I have two examples. This is a theoretical piece by Planchet et al., published in 2017. Authors make clear that health system resilience governance relates to the implicit and explicit rules, institutions that shape power relationships between actors and the actions of these actors. So I think this is a very important piece of work, published very early in the discourse of health system resilience. However, most other studies refused to work with these important insights of that particular article. Another article which is applying a global health lens by Remco van de Paar et al., also from 2017, published in Health Policy and Planning, interrogating resilience in health systems development. Here, authors state another example for critically engagement with health system resilience. Authors state, with the resilience focus on permanency of crisis, we fail to consider alternative political and moral policy pathways rooted in the principles of social justice, investing in global public goods for health. However, again, these two examples are not representing the mainstream of health system resilience literature. So what are the gaps? Political determinants are treated in a fragmented way in the literature. Political science explanations, theories are very seldomly applied. Instead, resilience is framed as a technical or managerial issue in many studies, even if these studies refer to governance and some fragmented political determinants. Structural inequalities and institutional barriers remain under-examined. This leads to a risk, at least I think so. So resilience discourse can be co-opted, depoliticized, and even used to reinfuse the status quo of a health system or of global health policies. So my conclusion from this literature review is that we need a more systematic political analysis of health system resilience. I have done this very briefly for the German case. So if we turn to Germany, we see that before COVID-19, resilience meant only individual coping capacities. So individuals, patients, physicians, nurses should become resilient in order to cope with the day-to-day shortcomings and challenges of the health system, like heavy workloads or waiting lists and other shortcomings too. During the pandemic, however, the focus shifted towards organizational and infrastructural resilience, other dimensions of the concept. There are criticism of over-provision, resource deficits, staff shortages, and called for a more data-driven policies, clear responsibilities, stronger state role in order to make the system resilient in the face of any new crisis, even if stakeholders do not know how the next crisis might look like. I will give you one specific example. Here I refer to the article which I published together with colleagues in 2022. It turned out during the pandemic that the public health service, the third pillar next to inpatient and outpatient care of the German health system, was overburdened during or throughout the pandemic. And of course, there is an institutional explanation for that. Germany is clearly a two-tier health system where public health is subordinated to the very strong hospital or healthcare sector, but especially the hospitals are very, very powerful. And the public health service, which is the third pillar of the system, is chronically underfunded, and especially the local public health departments, the so-called Gesundheitsämter at the local level, were overwhelmed during the pandemic. And you might wonder why you see a fax machine on this slide. So the fax machine was the negative symbol of the local public health departments, because these around 400 departments in Germany depended on the fax machine to communicate with other departments, but also with the regional and federal level of public health institutions. Yeah, so the digital infrastructure of the public health service is clearly underdeveloped in Germany. The government responded with an unprecedented investment, 4 billion euros in 2020. But so that was a major investment and really helped local health departments to gain new personnel and a better technical infrastructure, but it did not fundamentally alter institutional hierarchies, which means that the public health service is still subordinated to healthcare and hospitals in Germany. So this, I hope this at least explained a little bit the political reality of resilience in Germany. The concept is very appealing for politicians, even a myth-like. It's even a myth-like concept. It's used affirmatively without deeper critique. Structural conditions, which are of key importance for the German health system, for instance, corporatist self-governance, veto players such as physician associations, or as I just explained, the weak integration of public health within the system remain intact or have not problematized by resilience policies. Anyway, if we have a look on the political context, we see that the former center-left government, the so-called traffic light coalition, in power from 2021 to 2025, proposed rather ambitious health system resilience policies, rather ambitious reform proposals like community health nursing, autonomous health regions, and some other policies as well. But these attempts were instantly blocked by veto players like hospital associations, but also by the associations of general practitioners. And these associations are very powerful within the German corporatist self-governance system. So there was no chance to apply more or to implement more progressive health system resilience policies. The current center-right government in office since May 2025 interprets resilience differently, mainly in fiscal and security terms, and focuses on proper health insurance finances, hospital structure, better working conditions for nurses, and a crisis preparedness in a very, very broad way, including also to prepare for the case of war, something like that. So I would say the current government pursues health system, a concept of health system resilience, which is in line with the status quo of the current health system. So I come to my conclusion. Health system resilience is a framework which is currently framed as a technocratic tool, but it's not just about coordination and planning. It is, at least this is my understanding, a political task. So we must ask, if we use this concept, who benefits from resilience, which values guide resilience policies, which structures need reform. And I think true resilience means more than bouncing back to a status quo ante of a system. It means negotiating societal goals, strengthening public health, and building democratic resilience. Only by repoliticizing health system resilience, we can ensure that it contributes to justice, solidarity, and sustainability in a broader sense. To wrap up, I would like to leave you with 3 questions. Of course, you do not need to discuss them, but maybe you like to respond to 1 or 2 of these questions. First, what risks do we face if political factors like power asymmetries or institutional constraints are left out of resilience research? Second, in your own context, do resilience policies reinforce existing structures, or have they led to real change? And third, what kinds of actors or reforms might be needed to strengthen democratic resilience in health systems nationally or globally? So I close by acknowledging the work of scholars who inspired this research. And thank you for your attention. And I look forward to your questions and discussion. Thank you.
Well, thank you so much, Dr. Ewert, for that very enlightening presentation. And I should add, we were very fortunate to host Professor Ewert this summer here when he was a visiting scholar at the Dadala Institute. So that's where he piqued our curiosity around this concept of resilience and what it means. And I think you've really outlined the issues so clearly and comprehensively. Very impressive. And perhaps I'll start with the first question. I actually find it very interesting to see, both, your findings in the literature that although resilience is used as this kind of managerial term, the depth of analysis from a sort of a political lens is really missing. Fortunately, you've been able to highlight some of these factors that really need more focus, such as the, sort of the corporatist approach to sort of decision-making and power structures. And for those of you, because we're not all political scientists here, the corporatist lens is basically a decision-making table, or at least a dialogue table, where the key stakeholders in a healthcare system meet regularly and negotiate how a system will be structured. So in Canada, this is at federal and Canadian Medical Association dialogue, as well as the provinces. So you have kind of that tripod, and then the provincial provinces or the health insurers. So at that level, it's really the provincial government and the medical association. So they really do have a lock on, when they talk about resilience. I love your question, in whose interest, because the decisions always end up back at those tables in terms of major structural reforms. And that's often why we don't see a lot, because the systems are designed to support those people who are at those tables. But my question was around what's so fascinating around where I see the parallels is, even though COVID was a public health crisis, and so that COVID is SARS-CoV-2, it was really SARS initially back in 2003 that led to the establishment of the Canadian, the Public Health Agency of Canada. It didn't exist before SARS, and when SARS-CoV-2 happened, it sort of kicked into gear to try and do some meta-governance of the provinces and help align their strategies. But really, it seems to be public health, it only really comes out during a crisis, and otherwise it's a very local matter, focusing on very regionally, vaccines in schools and those kinds of things, and other kinds of public health measures. So I found that very interesting. So I guess maybe my question is, where do you see, do you see public health remaining in the background? Because, we're at a time when there are so many kind of crises upon us. Even though COVID, we're sort of in a post-COVID period, zoonotic illnesses are out there. There's bird flu, and it could mutate and become infectious to humans at some point. So what are your thoughts around that?
Yeah, thank you very much. Very interesting question. I definitely see public health stakeholders not in the same position as healthcare stakeholders. I mean, I heavily draw from the German health system, but also, to my knowledge, in many other European health system where I know a little bit more about these systems, public health agency are seldomly at the same level than healthcare inpatient or outpatient stakeholders. Sometimes it's a little bit different if primary care plays an important role in these countries, and if primary care is defined in a broad way, not only in a way which is circulates around individual diseases, etc., but also about questions what health in all policies, healthy environments, healthy ecologies, etc. So, but yeah, you're right. The COVID-19 did not really change this situation, and in Germany at this moment we have the strange situations where the healthcare stakeholders seek to care a little bit more about public health. Yeah, so which means the public health service is still subordinated, is not making decisions at the federal level on the future of the German health system, which is basically a healthcare system. But the federal government speaks in many reports about public health and motivates healthcare stakeholders like hospital associations or physician associations to care a little bit more about not the individual patients, but also about the broader populations. Yeah, and that's rather strange. Yeah, but maybe some of our students made different experiences within their health system.
Yeah, right. So would any of you like to respond to that? Any observations? Yes, go ahead, Brian.
So I have a question. So resilience is another word for adaptability, right?
Yeah.
So that's Darwinism 101 is what you're preaching, right?
Yeah, I guess it's a form of survival. Yeah, if you want to survive, you have to adapt. Yeah.
I mean, this is open to discussion. What exactly resilience mean? It's capability. It's to adapt, to survive, but it could also means to transform, to learn your lessons during a crisis and transform the system. So this is open to discussion.
Any other thoughts, or do you want to follow up, Brian? No?
Oh, well, so Michael Porter at Harvard said that you cannot manage large organizations to the exception to the rule. So COVID is an exception to the rule. And in Canada, the government threw out at least $500 million worth of PPE stuff.
Yeah.
Who knew a face mask had a shelf life, right? So that means that in order to be adaptable to all the projected new diseases and everything coming around, that means the government would have to put billions of dollars in inventory, which will become stale dated before they might get to use it. How do you sell that to a government?
Yeah, I mean, maybe you don't have to have the actual physical mask, but there needs to be an industrial capacity to ramp up in a time of need. But even that, I guess, there's still an investment.
I was in Malaysia. Remember when SARS first came out? I was in Malaysia the day the price of the latex gloves went from $5 to $55 US. And I was in Malaysia the day, not the day, but the week that the supply reached the demand. And what happened is the price dropped back down to where it was. And people were walking away from the letters of credit, right, and reordering. And what everybody feared is getting stuck with dead inventory that they couldn't flog. And then because there was so much fraud around it, the first time you went to talk to somebody, they would say, talk to your lawyers first. They want, like you try to sell a thing to Health Canada, they want to talk to your lawyers first. And what it did is, instead of you were trying to speed things up, what it was doing is stretching out the whole cycle from ordering it and getting it into the hands of the end users, right?
Mm-hmm. Okay. And what exactly is the link to resilience? So sorry, I didn't get it.
No, the point is that if the whole resilience is adaptability, the forces driving behavior within a healthcare ecosystem actually hinder it. It's so complex, and that all of vested interests, stakeholder groups that, and here we fought in Canada, or certainly in Ontario, the doctors fought pharmacists doing prescriptions. It was a big battle, right? So it seems that the forces are in competition with each other, right? Mm-hmm. That doesn't give you much resilience when the next version of COVID comes around.
No, that's true. Those kind of political battles.
Yeah, I'm sort of agreeing that the biggest
yeah.
problem is probably political, right?
Yeah. Any other thoughts? Go ahead, Kathir.
Hi, Professor Benjamin. This is Kadir Vail. How are you?
Oh, hello. I'm good. Thank you. Hi.
Yeah. So, a wonderful presentation. So, my question is related to the which you mentioned in the last point on democratic resilience. And I was just thinking of how you can actually kind of link the resilience, assistant resilience with the equity principles, because that is one important underpin principle which needs to be focused on when it comes to the resilience. So that is one question. The second question is related to the kind of, because I'm basically trained as an epidemiologist, so in a perspective of epidemiologist, we do great things like in case of an disease outbreak, we say it's an outbreak, this is an epidemic, this is a pandemic, all these kind of creating kind of things we do, and accordingly the responses are set. But the same thing if I see in the resilience concept, there may be some kind of resilience or adaptations need to be done very locally in a small scale manner, and resilience, which is actually kind of expected, similar to what happened with the COVID. So what is your kind of thoughts on this?
Mm-hmm. Thank you. It was very difficult, so there was a little bit noise to understand these two questions. The first one was on democratic resilience, right?
Yeah, that's related to the equity principles. How equity?
Equity, yeah.
How you are linking the equity principles, or thinking of bringing the equity principles within the resilience.
Mm-hmm. Mm-hmm. I'm not sure whether I understood this question right. I mean, I'm not totally sure whether the concept of democratic resilience is useful if we apply a global health lens, because it's highly normative. So we with democratic resilience, so we clearly state that it needs democracy and a democratic process to reach a certain level of resilience. So I think it would be worth to critically discuss this, whether it makes sense to link resilience to democracy. I would say it's absolutely necessary in at least in the German context, but I'm not sure whether this is useful at a global level. And sorry, I didn't get the rest of your question. Sorry.
I have a question, Mary.
Hi, Michael.
Yeah, I think, Catherine, you should finish up, or?
Yeah.
Oh, sorry.
That's okay.
So I brought the equity principle because the article which you shared as a resource reading material, so which should specifically identified one of the bottleneck as the nursing homes, where the people in the nursing homes are primarily getting affected, but there is hardly any policy change or any kind of resilience mechanism happening over for the nursing homes related areas. And so that is why I thought of bringing, kind of asking your thoughts on linking, how you kind of thought of linking equity principles in this situation.
Mm-hmm. Mm-hmm. I mean, the example of nursing homes and in Germany is a very good one, because the political clout of nursing companies and nursing stakeholders is very weak, and it turned out throughout the pandemic that the government, it took very long until the government took notice of nursing homes. And so because the situation was more or less neglected. So the argument in our article is that each and every health system has some neuralgic points or bottlenecks, which are even a problem in times where there is no crisis. But if we face a crisis or several crises at the same time, then these bottlenecks become highly problematic. In the German case here, the problem was that there were only, well, the lobby, the political lobby of nursing homes were rather weak, and they were not able to shape resilience policies when the government discussed them. So the resilience discourse in Germany was dominated by physician associations in hospitals, but not by stakeholders from belonging to the care sector. Sorry if I do not answer to your question in the full sense. It was difficult for me to get it.
Okay, well, thank you. Actually, Lasika, you were next.
I was just going to say that Michael had a question. That was.
Oh,
so.
okay. All right. Yeah, Michael, please go ahead. We don't see you. Oh, there we are. Now we see you.
Oh, hi. Benjamin, wie geht es dir?
Mir geht es gut, danke. Grüße nach Berlin.
It's sehr gut. It's good to see you again. My question is a conceptual challenge, not necessarily to your paper, but to the concept of healthcare resilience, because for me it's not clear at my starting point, resilient against what exactly? And this comes to mind because you may have read Ulrich Beck's Risk Society, and for the rest of the group, the main argument there relates to the absurdity concerning society's preoccupation with risk, highlighting a paradox in modern societies in which there are advancements in technology and industrialization that are intended to help solve problems, but these themselves simultaneously create new and often difficult unforeseen risk. And that's a key word there that came to mind when I was reading this paper, because I think this concept of health resilience looks towards the future and could be seen as preparing perhaps for another COVID. So what I'm trying to suggest here is the ineffectiveness inherent in the concept of health system resilience, and coming to it from a slightly different angle as an effort to reduce risk by making health systems more resilient, such as to have adequate testing equipment, which is one of the examples in your paper, for a disease no one saw coming. And I don't know if this is something that in preparing, in looking at this concept, whether that ineffectiveness in attending to future problems that no one knew, or the scale and scope of them, was something that was reflected on.
Mm-hmm. Thank you very much. So basically, you are suggesting that it's almost impossible to become resilient against risks which health system stakeholders do not know here and now. So I think that this is a very important point, but because many of the health system resilience policies imposed that the next crisis again will be a pandemic, rather similar to COVID-19, and if this is right, at least the German health system resilience policy totally made sense. They strengthened hospitals. Nowadays we have more emergency beds and emergency and nurses who are capable to work with emergency patients, etc. But of course, it might be the case that the next major public health crisis has to do with climate change, or in combination with NCDs or etc. So, and then you're right, such a response does not make sense. But the question is, how should the government deal with the unknown? So you're right, but how should the government deal with the unknown?
I wish I knew the answer, Benjamin.
Yeah.
So yeah, I was interested to know more about the financing aspects of building back better. So
okay, financing, yeah.
Yeah, how are countries preparing for upcoming potential emergencies or public health catastrophic like COVID when it comes to finance? I know some countries allocate resilience fund for those sorts of emergencies, but what has been the trend so far in Germany or global north?
Okay, I think the difficulty during COVID-19 was that emergency funds only, or most of the emergency funds strengthened status quo stakeholders like hospitals and mostly hospitals. So there was no future-oriented funding, because decisions were made already during the pandemic, and the whole resilience discourse was constrained by the COVID-19 experiences, and this framing made it very difficult to turn the focus to other stakeholders like nursing homes, like public health agencies, local public health departments, and they were not really in a situation to make decisions on what resilience and funding for future to prepare future crises could mean. And this 4 billion fund for the local health departments clearly was an exception.
Right.
So,
Okay. Go ahead.
Hello, my name is Chelsea. Thank you for the great presentation. Can you hear me okay?
Yes, I can hear you.
Okay. I found it very interesting, especially also the article that was shared. I have experience living and working in Germany, so it brought a lot of inspiration. Oh, sorry. So one of the projects I was previously part of was looking at national adaptation planning and interviewing stakeholders involved in that within Germany. And one of the things that was found was there was a lot of between ministries and stakeholders, people weren't necessarily aware of what other ministries were doing in terms of the planning and work. So there was a lot of gaps as well as repetition. And when I was reading through the article that you were a part of, it was talking about how there was some kind of fighting between federal, state, and local authority over who was responsible for certain aspects within the COVID planning. So I was just curious about your perspective, like from Germany, and maybe also how it can be applied beyond, about how we can strengthen these roles of like better coordination and collaboration, especially when there's a lot of bureaucracy in clarifying the roles. So yeah, it's just kind of some commonalities I saw within the research, which I'd be interested to learn your perspective on.
Yeah, thank you. In Germany, so nowadays the federal health ministry, but also the health ministries at state level, like Bavaria, Hesse, or North Rhine-Westphalia, all these health ministries are in their policy briefs and reports, they are mentioning the concept of health in all policies as a silver bullet or a magic panacea against public health crisis or each and every health crisis. But at least what and I think we made this rather clear in the article, that the sectoral boundaries within the German health system are so strong that even within the health system, health in all policies, integrated care, collaboration between inpatient, outpatient, or healthcare and public health is very difficult to reach. Anyway, during COVID-19, it was possible. It was possible because there were ad hoc governance bodies, so at the federal level, ad hoc governance which outruled the normal governance procedures. And this was experienced by all stakeholders as something good and a way we should respond to future health crises. Anyway, this discussion or this experience is not combined with suggestions for structural change. Yeah, because of course this worked rather well. Germany did rather well during the pandemic due to this health and all policy emergency response. But to learn from that would mean to make integrated care work, to strengthen subordinated sectors, and build bridges to social work, to other policy fields, etc. And I do not see, unfortunately, major activities which point to that direction. But this would be necessary. But health in all policies, in combination with health resilience, is another buzzword within the German health policy discourse at the moment.
Thank you.
Okay, well, thank you so much, Dr. Ewert, for that really insightful presentation and updating us on some of your research that you started or were working on while you were here. I hope you will please send us, a link to your future manuscript that when it is published, because we will all be
I will.
We'll be eagerly interested in seeing sort of the next stage of your, how are you end up articulating all of these concepts so brilliantly brought. Yeah.
Thank you. I will certainly do that. The article is under review, and hopefully it will be published in the next month. Yeah, thanks. Thank you for having me.
Thank you, and we really appreciate your moving the field forward so that political lens, you know, which is so powerful, gets incorporated into these concepts. And so, yes, thank you so much.
Okay. Have a nice rest of the day. Bye-bye.
You too. Have a great evening. Thank you. Bye-bye.
Bye-bye.